Members of the board were watching a video, Zoom video I've recorded with Senator Wayne Steinhauer. He has been the leader in evaluating Medicaid expansion. He has a business background. To give some background about him, he's been involved in the business community. Says he couldn't keep a job throughout his career, so he's been with Osted's, Starmark, Ansbury Group, and he owned a hotel in Murdo. Welcome, Senator, and thank you for joining us for this session. Let's start. Well, most of this is Medicaid expansion. Let's start with what Medicaid is. Before I do that, I sent you the summary we sent to the board. Is that for the most part an accurate portrayal?
Yes, it is. Yes, there is a Medicaid report out there. I think you might have pulled a lot of the data from 19. I've got 20 data. Because when I was introducing the bill, the 21 data wasn't out yet. So,
okay. Thank you. And as a reminder to the board, the senator sponsored a bill taking the position that the legislature should adopt so it can manage better Medicaid expansion. We did not support that bill. We did not oppose that bill. We stood by and watched it die, which is, as we will get to, part of why the proponents are putting this in the Constitution. We did, however, support his bill that will take some of the extra money you will learn about and sequester it to pay the expenses down the road. That's coming up in the future. But Senator Steinhauer has walked through this issue more than anyone else. He was going to be out of town during the meeting, so I've invited him here. Let's do a Medicaid review real quick. Medicaid has been in place since 1965. Our report, using 19 information, says that there's about 117, maybe 120,000 people on Medicaid as an average monthly enrollment. That's a lot of people. And that the total cost of that in 2019 was over 900 million. The state share of that was 400 million. I'm not sure you've ever been an appropriator. I can't remember, but that's about 40% of the money we raise in state. State has about a $4+ billion budget, about half of it's federal money. Before we get into expansion, is there anything you want to say about Medicaid as it's existed for over 40 years?
Well, Medicaid is not a requirement that states participate, but every state and the District of Columbia offer Medicaid. 38 states have expanded, plus the District of Columbia. What the states offer, federal legislation requires certain things to be offered, and then you can file a waiver to add to the programs. South Dakota being, and I think Senator Boland will probably tell you, we're a low tax, low service state. We don't offer as many optional things in our Medicaid in the state of South Dakota than some of our surrounding states. Hence, our cost per enrollee is a little lower than you'll see in other states. It also has a lot to do with our reimbursement rates for the services provided, but we don't offer as much as some other states.
It's important. I want you to review the state actually sets how much medical providers get paid for Medicaid cases, right?
Right. We've got several dials that we can turn. I spent a lot of time looking at nursing homes, several dials that we can turn. We could reimburse at a higher rate if we chose to. So if we look at expansion, very important, of those total costs of Medicaid right now are split 44% state, 56% federal government, if I have that right. Yes, and it ebbs and flows because each year what they call the FMAP gets reset based on how our state is doing compared to the rest of the country in terms of average income. In a nutshell, oversimplifying it. Let's turn to Medicaid expansion. I'm going to ask you a couple quick answer questions and then turn you loose to share your experience. Who will be eligible for Medicaid under the expansion that's not currently eligible for Medicaid? Well, let's just recap, if you don't mind, who is covered, right? So currently, poor under the age of 18, poor over the age 65 and older,
And anybody that's already disabled at any age or blind are taken care of. And so what is going to be in the expansion population would those be those between 18 and 65 that aren't disabled, that aren't blind. And so some people sometimes refer to those as able-bodied people, and I probably have made that mistake once in a while, but you know, a person that outwardly looks able-bodied might be dealing with a chronic illness or have mental health issues that need to be dealt with. And so it's those 18 to 65. 68%, David, of our recipients of Medicaid today are kids under the CHIP program, Children's Health Insurance Program.
A good portion of the expanded population are currently are working people. Is that correct?
Yeah, it could be if working poor individuals. Yes.
Okay. How many people will be added to the Medicaid rolls with expansion?
Well, that's a point of debate, isn't it? When we start talking about costs, right? And if you don't mind, a little bit about my journey, right? So I was appointed to the legislature by Dugard, and my first year was in 16, and Dugard was leading up to a proposal to expand Medicaid, and then everybody was shocked we got a President Trump instead of a President Clinton. And at that time, I was concerned about whether we could afford Medicaid. Governor Dugard had a high cost estimate. He didn't want to be, at that time, I think 32 states had expanded. He didn't want to be the 33rd to underestimate the cost. So he had a very high cost estimate. So a little bit more about the cost. When the estimates started to come out, when you start a circulation for an initiated measure, a constitutional amendment, LRC is going to do a cost estimate. And I looked at that early on and I said, holy crap, how did this get to be so low? David, I've spent a lot of time with it. I've come to believe that LRC's estimate, and we spend more time on this, is, if anything, it's conservative, meaning that it's higher than I think it might come in.
I just want to make a note for the board members that are currently on our board. We, in fact, endorsed Dugard's attempt to expand Medicaid. We couldn't get a lot of business groups, and it never really got off the tarmac. It kind of ran out of gas before it got airborne. And that proposal had some things to do with Indian health and full reimbursement for tribal members. That's not part of the expansion. But anyway, wanted to remind the board and yourself that we, in fact, endorsed that proposal. So let me turn you loose, because one of the big contentions is how much this is going to cost, how much we get from the federal government, should we take that money from the government? And so finish your journey and share with us your conclusions. Thank you.
Well, I note that in the handout, I think that you've given to the board on page 5, you've got that LRC estimate for this proposed constitutional amendment, which is a 5-year look at what it's going to do. And if your board members have that in front of them, I'd encourage you to take a look at that. It shows a 5-year projection, because in the first 2 years, under the ARPA plan, Biden has provided an incentive to the 12 states that haven't yet expanded, that if you do expand, you're going to get an extra 5% FMAP on your existing Medicaid dollars, not on the expansion, where we get all wrapped around the axle about how many people. So we can calculate what that amount is. And for the first 2 years after we'd expand, we'd get about $52 million in change. Let's call it 105 over the first 2 years. That's represented in this column. So in this chart, if you've got it, if you go left to right, you're seeing that LRC is estimating that there's going to be 42,500 new enrollees because of expansion. That's covering people up to 138% of the poverty line that are between 18 and 65. Then they're projecting the total cost at $297 million. The state share, interestingly enough, they're showing at 32. Here's the reason that's interesting, is because the expansion costs are covered at a 90% FMAP. The state picks up 10%. Wayne, 32 million is not 10% of 297. I get that. So the difference is administrative costs were estimated by LRC, and we don't get that same 90-10 match on the administrative costs. So that's why it's 32 million. So the way they chose to show this is the cost for the expansion, the cost that the state is going to bear, and then the last is the total general savings dollars. And you see in those first 2 years, it's 63 and $64 million. 52 and change is coming from this ARPA incentive for expanding. The extra 11 million that you see ongoing in years 3 through 5 on this chart is a result of a variety of things. Some of our individuals today, we get that, let's call it a 60-40 match in the FMAP, right? Normal FMAP, and they might be an individual who's, let's say, is blind and doesn't have any kids. And in the future, we can reclassify him as a single adult. And instead of getting 60 cents on the dollar, we're going to get 90 cents on the dollar. So we had a few $1 million savings there. You mentioned the Dugard expansion, where he was going to save on duly eligible individuals on the IHS reimbursement. You know, by treaty, the federal government's supposed to take care of Native Americans, but they have to go to an IHS facility. Well, if they go to a organization, healthcare provider that's got a continuity of care agreement, we can get 100% reimbursement. Dugard was going to pay for his estimated cost entirely out of that savings, but built into this projection is only about $2 million of Native American healthcare soft savings. Other things are, and this is a real burden for counties, if you go to jail and you've been on Medicaid, you don't continue. When you're incarcerated, either by the state or the county, it's 100% a burden for the state and or the county. And when you go, if you're in jail and you have to go to get a medical procedure, if you're there for more than 24 hours, we can put you back on Medicaid. Well, it's always been at 60%. Now it'll be at 90% if you're Medicaid eligible. So there again, we get a couple $1 million. So that is some of the major pieces that turns into an $11 million ongoing savings in the expansion population. A couple more things about this chart. You'll notice that LRC is projecting the annual growth in the number of enrollees. Well, experience tells us, if we look at North Dakota, for example, that they have 19 to 20,000 enrollees in the expansion population, and it ebbs and flows each year. Because if you need a medical procedure and you're eligible when you're 38 years old, it doesn't mean you're going to be needing another one when you're 39. So the number of people that are involved changes. And so this steady growth is, again, kind of an optimistic, depending on how it's projecting costs high. So when I first saw this and I looked at it, and after 5 years, the net cost is less than $4 million. I don't think that's a fair way to look at it, you know, because the run rate going forward is, if you look at this, is about $22 million and change. You take the cost less the $11 million ongoing savings. 22 to 25, we're not that good. Let's call it a mid $20 million number. How can you prove that?
And that's the number the state's going to have to come up with after the first 5 years.
Yes. Yeah.
Thank you. Thank you.
And if they don't do things right, and that's why I had Senate Bill 102, they might be doing it right away, because, you know, we have a tendency in Pure, if it's not ongoing money, we count it as one-time money, right? And this is not ongoing money. That $52 million isn't going to be there in the 3rd year. And so one-time money, we like to spend on projects. It might be a new visitor center in a park, or it could be a new 4-lane highway to who knows where. This money is given to us for expansion. I thought it should have been set aside, but that's crying in my beer, because I didn't get the bill passed.
Critic, are you comfortable that 22 million is the number ongoing? Because I know we'll hear from some healthcare folks, they think that's a touch high.
I think it's I think it's touch high. And let me explain that. To me, there's 2 cost drivers to this thing. It's how many enrollees do you have, right? And what does it cost per enrollee? So, you know, if you look at the number of enrollees, I've already touched on it. North Dakota has 19 to 20,000 people. They don't, enrollees in the expansion population. Their state population is a little less than us, so we know what the difference is. We can spruce that up. That would tell us that South Dakota should be having about 22,000 enrollees. Well, LRC is forecasting 42. So LRC could be off by a factor almost of 1.
As I've studied this, not as extensively as you have, I think some states have underestimated enrollment, some states have overestimated. but North Dakota seems to be a fairly good operating model. And I will point out for board members, Sanford Health was actually the third-party administrator for the expanded Medicaid there for the first few years of the project, if I have that right. Please continue in your.
Well, yeah, to your point, I think early on, the states had done a really poor job of forecasting their costs, and North Dakota would be an example that did a little better. Kaiser Family Foundation that studied the heck out of this. The neat thing about being one of the last 12 to expand is that we've been studied a lot, right? So they had looked at North Dakota and it had forecast an expansion population bigger than what they realized. And Kaiser Family Foundation now has gone to school on that. They're still saying that we might only have, I think the number was 27,000 enrollees in the state of South Dakota, not the 42 that LRC came up with. I'll have to look that up, David, but their number is smaller than, and they had forecast where North Dakota was. Back to the number of enrollees. Again, I've already said if you spruce up our population, you'd end up with about 22,000 enrollees, not 42,000. Here's another thing that's interesting. We can take a look at who we already offer Medicaid to. If you're a pregnant woman below 138% of the poverty line in the state of South Dakota, you're eligible for Medicaid. 138% poverty line, same as what the expansion population is, right? So it's 18 to 65, 138%. I have to digress because I always like to put a little dig in on the federal government, right? You might hear from time to time that it's not 138, that it's 133% of the federal poverty line, right? Well, only the federal government can say, we're going to ignore the first 5% of your income when it comes to this. So sometimes you'll hear expressed as 138, sometimes 133. Let's stick for simplicity at 138. So we take care of pregnant women today to 138% of their income. So of all the pregnancies that we have in the state of South Dakota, guess what? 8% of the women are taking advantage of Medicaid. So that tells you that 8% of them are below the poverty line and accessing Medicaid. Well, interestingly enough, we just had a census done. So we can take a look at what the population is between 18 and 65, and it turns out to be 522,000 people in the state of South Dakota are in that category. So how many of them are below 138% of the poverty line? How many of them would access Medicaid? Well, again, LRC's forecast 42,500 people that are going to enroll and take advantage of Medicaid. That also is 8%. Now, why in the world would a 38-year-old male need health care as often as a pregnant woman? I'd submit to you that all pregnant women need health care. So this 42.5 is a high number, a couple of different ways you can look at it. The other major cost driver is, as I mentioned, is what does it cost per enrollee? Now, if you go to that Medicaid report, you'll learn something that's pretty darn cool, and that is that the cost per enrollee, we currently are having, I think the updated number is about 115,000 enrollees. Again, it ebbs and flows, $992 million in 20. We can do the math and we calculate out that per enrollee, it's costing us $8,566. But the other thing this report tells us, and it's no shocker if you think about it, 60% of our South Dakota Medicaid costs comes from elderly and disabled. Well, think about it. You're going to need medical services more in your post 65 as you get older and more frail. I should talk. The 55% of the beds in nursing homes in the state of South Dakota are funded by Medicaid. Disabled people, wards of the state cost more. So we've already taken that group out, and we can do the math. 60% of the cost, 20% of the people. Those folks cost us a tremendous amount of money. Subtract that away, and what do we get left with? We get left with non-disabled, non-elderly. On average, they're only costing us $4,200 a month. Or a year.
Senator, your comparison between pregnant women and guys ignores guys that look like they're pregnant because of beer bellies and they have higher health costs probably. We have 3 or 4 minutes. I want you to address a couple other things critics have said and compare it to your journey. One of the fears they have is that the Fed will change that 90-10.
Yeah. Yeah, I don't see
and
that
screw up
happening.
the FMAP.
Well, first of all, you got 38 states that expanded, so senators aren't going to vote to, let's take the Senate, for example. So you aren't going to get them voting to screw their states financially. What they might do if they ever wake up and realize they're spending money like drunken sailors is they might say, okay, you're going to have your standard FMAP. Instead of 90-10 on the expansion population, we'd be looking more like 60-40. David, I just wanted to finish, if I may, on that cost per basis, right? The cost per thing, LRC's estimate is high because, again, if you take out disabled and elderly, they've already been taken care of, we're left with $4,200 per enrollee. And if you take that times the 42,500, you're at 27 million, less the 11 million. You're in the teens in terms of our costs. Either way you look at it, we've got a high estimate on the number of rollies, and we got a high estimate on the cost per.
As a final question, your reaction to the able-bodied people. You addressed the fact that a lot of them aren't. A lot of them are employed but work for businesses that don't offer health insurance. Is this a good way to make sure that they're seeing doctors and taking care of health issues to put them on the government role?
Well, Kaiser Family Foundation has done numerous studies looking at this, and then even did a study of studies, and most of them will tell you that now this is a positive. Here's the thing. Ohio saw that in their expansion population, 15% more of them were employed than before. And those that were in the expansion population said it was easier to work. Well, think about it. If you've got a person that's got a chronic illness and you aren't offering insurance, by the way, they're going to be missing work more frequently. This will help our employment population. And so I think it's the right thing to do. A couple other things to keep in mind. So this is by LRC's estimates, about a $300 million program. If that money just churns twice outside of healthcare, where we have a 4.5% sales tax, you're going to get $27 million, right? Other things to consider, is it's going to do wonders for that Native American population, because when they go to an IHS facility, instead of using a limited amount of IHS dollars, it'll be on Medicaid government picking up on those folks 100% because they're duly eligible. And that budget lasts longer than for even any of the Native Americans that are accessing an IHS facility. People say to me, Wayne, but don't hospitals and counties have to take care of people without health care? Well, yes, but it's only emergency care. It doesn't provide that maintenance of care or that follow-up appointment. Counties are spending over $1 million, almost $2 million a year across the state of South Dakota. This would help them.
Senator, thank you for your time, sharing your knowledge. I want the board to understand that Senator Steinhauer is one of a large group of legislators that studies issues, interacts with the chamber. You've been a good business advocate and a very thoughtful legislator. Thank you for your service, and thank you for your time today.
Thank you.